So when assessing a patient where we think we have a relapse, what do we take into consideration? The first point is obviously very important to ensure that the patient doesn't have worsening of neurologic functioning because of co-occurrence of another disease. Second point to consider is, when did the symptoms start? Did they start within the last few days? Are the symptoms worsening? So is there a crescendo to the symptoms, or have the symptoms plateaued? If the latter were the case, we normally do not consider treatment of the attack unless the attack is severe enough. I'm thinking of a sensory attack. If the patient is still in the period where the symptoms are worsening and we have satisfied the fact that there is no occurrence of another condition, then we consider treatment of this particular attack. Considerations around the treatment can include first-line steroids. Alternate interventions could be plasma exchange, depending on local availability. Very often that requires hospitalization, or potentially ACTH. A patient is diagnosed with relapsing forms of multiple sclerosis. Why do we consider treatment in this patient? That's an important question. From my point of view, MS is at this point in time a treatable or manageable disease, and appropriate intervention at an earliest possible time point can help us thwart the progressive form of multiple sclerosis, and it may also help us prevent for a patient to have disability accumulation. And I'm not just talking about physical disability accumulation, I'm talking about cognitive decline. I'm talking essentially to maintain the patient in a functioning state as if they had no MS. And so, what is the goal of treatment with MS medications? The goal is to have as little manifestations of the disease as objectively reachable in a patient. If a patient has new lesions on brain MRI, a treatment change should be envisaged. If a patient has a new attack, a treatment change should be envisaged. It becomes a little bit more difficult when we think about cognitive changes, because for many of the agents we don't have the data to support this. Nevertheless, as a practitioner, if I have a patient that has changes that are impactful for their daily lives, for example for their jobs, I will consider treatment changes at that point in time. Why is it important to diagnose MS early on? It is important to diagnose MS and to reach a certainty of the diagnosis as early as possible, because we have now treatment options. All of these treatment options can potentially prevent the long-term consequences or help to reduce the long-term consequences of multiple sclerosis. And that's why it's important to diagnose early. It is not just to reach the diagnosis, but also to come to the point where treatment can be offered to the patient. It is then obviously important to ensure that the diagnosis is correct. In multiple sclerosis, we have a challenge that we don't have any specific disease markers to tell us that the patient has MS. It's a constellation of disease activity, MRI, constellation of exam findings that all need to be taken into account. It is important when applying, for example, the 2017 criteria for the diagnosis of multiple sclerosis, that one keeps in mind that these criteria are only applicable in patients that fulfill certain clinical criteria. A patient with multiple symptoms that do not allow a location or a localization of the disease activity needs to be approached with care before one gives a diagnosis of multiple sclerosis.